Hello and happy Friday. Welcome to our assisted outpatient treatment community of practice. Thank you all so much for coming, as always. If you received our email reminder, you know that we have Dr. Scott Smith here again to give a part 2 presentation to the intersection of serious mental illness and substance use disorder. We had Dr. Smith here in February to share his experience with us, and the discussion I felt was so valuable. We thought it would be fruitful to have a part 2. So we're always happy to have him. And as always, there's going to be a Q&A at the end. So feel free to raise your hand during the presentation or put it in the chat or save it for the end, whatever you like. So before I kick it over to Scott, of course, there are a couple housekeeping items that I do want to go over. So twice a month, as you all probably know at this point, we have Dr. Scott Smith here and available for a Q&A session. That happens twice a month. Next month, it's going to be Monday, August 11th from 11 to 12, and then Wednesday, August 20th from 2 to 3. So yeah, as always, Dr. Smith is an amazing consultant when it comes to this, when it comes to AOT work. So if you have any questions about AOT, feel free to drop into those drop-ins. Or if you just want to hear more of Scott's voice, you can, that's a good place for that as well. So also the toolkit, I know that most of you are aware of the toolkit at this point and have visited it in the past, but as you know, we're constantly adding new resources that we've developed with the help of our experts and community partners. So to save us a little bit of time today, I'm going to go ahead and drop the links of what we've added in the chat as opposed to going over them, and showing them to you. So yeah, if you have any questions or concerns about what I drop in the chat or just in general, any suggestions on things that you'd like to see on the toolkit or resources that you feel might be helpful, please don't ever hesitate to reach out. And yeah, so without further ado, I'll go ahead and pass it over to Scott. Take it away.
All righty. Thank you so much. So I wanted to follow up our conversation we started in February with a part 2. And for what it's worth, I would love a chance for a part 3 through 20 because there's really just so much to cover. And part of what we're going to spend a lot of our time before the Q&A on is just how dramatically the landscape has changed in terms of substance use and what the implications might be for our work. And I would love to spend more time on the specific drugs of abuse and really getting into a lot of the current trends, the effects that they have, what it might mean for our treatment considerations. So hopefully I will be invited back to elaborate even further on this. And like I said, today, what I want to really do is kind of talk us through some of the bigger, in my opinion, current drugs of concern, and bigger both in terms of their magnitude overall, like what portion of the population is using them, and magnitude in terms of their effects, their deleterious effects on mental health. So we're going to talk about THC, and we have to because we can't deny that legalization has had the effect of dramatically increasing its use. And this is all well and good, except we're every day, because we can now more freely study THC, we're learning that it might not be as benign or harmless as has been proposed. We also know that there's been this decreased perception of the dangerousness. And this, by the way, is an inevitable consequence of legalizing something, right? And we've known this about alcohol forever. People inherently don't see alcohol as that dangerous or concerning, despite the fact that the World Health Organization lists it as the #3 cause of disease burden globally. That when they studied, I think, 120 countries looking for the drug that was most impactful on society in terms of illness, loss of life, contributions to criminal behavior, violent behavior, they expected heroin or cocaine to come out at the top. They were distant to the #1, which was alcohol. And so we know that the effect of legalization is to create the sense of safety. And unfortunately, that sense of safety is broadly applied. And one of the things that we see is that there's a lot of concerns around the mode of administration. And I briefly talked about this back in February, but part of the most concerning trend is that new users are experimenting with forms of THC, such as dabs, waxes, that have a very, very high concentration of THC. And we're seeing a lot of adolescents ending up in the ERs, in acute psychotic episodes. We're just seeing a variety of very deleterious effects on overall well-being, coming in part from this poor understanding that, well, if it's legal, it must be safe. The other medication, obviously, class that we could add into this in addition to alcohol would be prescription meds or over-the-counter meds. We know that their abuse historically has come with kind of a seal of approval because they are useful. They're produced and prescribed by doctors. This makes sense, right? I also want to talk about changes in methamphetamine, new production methods like shake and bake in one pot, and also a change to the formulary for the types of meth that are widely distributed, especially those that are flowing in from our southern border via the cartels, and how different that meth is from the traditional meths, even those made with these newer cooking methods. We also are seeing a rise in synthetic opiates. And one of the things that has been a narrative for a while is that people are unwittingly getting exposed to fentanyl. And more research, including a lot of research being produced by the CVHJ, is actually finding that people have a preference for fentanyl over other opiates. In addition to its role as a cutting agent, because fentanyl is cheaper overall because there's, it's easy to lab produce, doesn't require, the importation of, an additional substance like the opium, which is not produced domestically or really much in this hemisphere at all. Collectively means that we're seeing a whole lot more of it, and it's directly associated with the overwhelming majority of overdose deaths in the US now. Somewhere close to about 70%, I want to say, in recent years of overdoses directly involved fentanyl. And then a newer drug that's starting to show up that I just want to briefly touch on today and give you some pointers on what to look for is xylazine, known on the street often as Tranq. It's a veterinary tranquilizer. We know that there's a penchant for people to abuse tranquilizers used for livestock. This is the most current one. Primarily, it's being used as a cutting agent for opiates because it extends the mellowing, that like rolling euphoria that you get from opiate-based drugs. What's very concerning is that it also acts to depress the respiratory system like opiates and collectively can increase the risk for overdose. However, it does not appear to respond as effectively to overdose agents. So Narcan doesn't appear to work as well depending on how much xylazine is actually in the opiate in question. So now I want to take a look at some of the drug trends going back to 2015. I'm going to highlight 3 particular years. 2015 because it takes us back a decade. 2019 because it was right before the COVID crisis, and then the most current year that we have data from the National Survey on Drug Use and Health. And that's where all of this data I'm presenting here comes from. I put the link at the bottom to where you can find the main page for this survey that's administered every year. You can select the report by year, going back actually to 1984. 1984 through 2014 are condensed together, but then we've got year by year from 2015 to 2023. 2024 data should actually be available in the next couple of months. And for those of you involved in any kind of organizational training, those of you who might be students, it's important to note as well that all of their data is presented in PowerPoint format as well, so it can make it real easy for you to whip together presentations if that's part of your responsibility. So starting with 2015, what we know is that among individuals age 12 or older, so the sample, the youngest age is 12, the number of individuals who used illicit drugs in the year. Now, what I want to point out first for 2015 is that they were still doing primarily past month illicit use. And this somewhat correlates to yearly use, but this was a change made in the survey procedures, and I just want to disclose that. But what we see is that the number one illicit drug of choice was marijuana. And interestingly, we're not going to see that change year over year. Marijuana remains the most common illicit drug used. What's interesting is that the reason they continue to include it, even though it's not illicit now in the majority of states, is for the sake of comparison year over year. Now, in 2015, marijuana use, we can see, was right at the top, followed in second place by prescription pain relievers. I want to point out another interesting corollary here. Prescription pain relievers overtook heroin very early on. And what was really interesting and at times confusing about a lot of the early overdose data is that a significant portion of overdose deaths were still occurring via traditional heroin, despite the fact that prescription pain reliever misuse gained popularity. And as I mentioned at the beginning, a lot of the reason for the rise of misuse of prescription pain relievers was that they were more readily accessible and you just had a copay on it. And it's far less intimidating to buy your drugs at Walgreens than it is in, a drug house. It's just, there's so many reasons. Plus, it must be safe. We've covered in other webinars extensively opiates, and I don't want to get too sidetracked on that, except to mention that there's a theme here. And that is that the more a drug comes with a seal of approval, whether that be legislatively or it's being sourced from a reputable, quote, safe source like your physician, the more readily acceptable it is and the higher the potential rates for abuse. Now, the number 3 drug at that time was cocaine. And if you go to number 5, we see stimulants, and number 7, methamphetamine. And what we're seeing in 2015 is there is still very much a preference for getting high in terms of that excitatory type of high. And that seems to start to change. So moving down to 2019, again, marijuana is still on top. And in the year 2019, almost 50 million adults admitted that they used marijuana. Now, one thing I do also want to point out about this, all these portions of data, is that they are not unique to a person. So somebody may have tried all of these and they'll be represented in all these columns. So this can distort slightly the actual number of people who used an illicit drug, so that 57.2 million people is assumed to be inclusive, but the number who used cocaine might also be included in the number who used marijuana, if that makes sense. So marijuana, number 1, again, number 2, misuse of prescription pain relievers. But look what happens with number 3. We see hallucinogens jump from number 6 to number 3. And it begs a lot of questions, right? So what is it about a hallucinogen that becomes more appealing? And how does it correlate with the effects of a prescription pain reliever or the effects of marijuana? After hallucinogens, we see another drug, take or remain in the same position, and that was prescription tranquilizers and sedatives. And now we see where cocaine falls. Cocaine drops down to the number 5 slot, and we see that they're kind of clustering together with the stimulants. Now, inhalants jumped a little bit in terms of its use. In fact, it jumped quite a bit, over 2 times the number of people started using inhalants. And what's interesting is depending on the inhalant used, the effect can be somewhat different, but it's all going to produce that quasi-hypnotic, basically it creates an oxygen deprivation state that can cause everything from this mild euphoria to a variety of hallucinogenic type experiences. Moving over to our data from 2023. Marijuana still leading the pack as expected. There's hallucinogens. They've now jumped to the number 2 spot, displacing prescription pain relievers. Now, we do have to give some credit to the fact that there have been a lot more restrictions put in place around prescription medications. Interestingly, yesterday I had a small surgical procedure, and if I grimace at all, it's because I'm in more pain than I expected. But what was so interesting was to see how much time was spent, and if any of you have had any procedures done recently, on kind of preemptively explaining why if you get any prescription opiates, it's going to be a small amount, it's not going to be renewed, and that here are all the resources for pain management other than using prescription opiates. This is a big change, right? I can remember, 15 years ago, breaking an ankle and essentially being offered like a 3-month supply of Vicodin. And, it's hard to, really paint how complicit providers were in, freely distributing these medications. And often I've heard, prescribers say things like, we didn't know how addictive or habit forming they were. But as somebody who's worked in healthcare for over 20 years, I can tell you that no, we've always had a pretty good idea that these were, basically diet heroin. Like this is not all that novel. Why did we hand them out so freely? Combination of factors. One thing is like patient demand. Those of you who've gotten healthcare recently might have been sent a patient satisfaction score. Healthcare is a competitive industry. It's actually getting less competitive as we see more and more hospital systems merging into, larger systems, but it matters to compete for patients. And one thing that patients like is when their doctors and prescribers treat them the way they want to. We can attribute the rise of superbugs, bugs resistant to antibiotics, to the same phenomenon where patients were demanding antibiotics, and despite physician and prescriber, hesitations, they would still give the prescription as opposed to upset the patient. Now, medical personnel are getting more comfortable upsetting the patient, realizing that they may, in fact, know better how to treat some of these things. Getting back to that, so for hallucinogens to jump up so high, we have to really be asking, like, what is this now telling us about what people want when they're using drugs, right? And there's a variety of reasons why people use drugs, but when we see drugs being used more and more frequently, I think we need to be asking the question of like, what is the benefit, right? And generally what we see is that all drugs, for the most part, have gone up considerably. Just highlighting some of the most major changes, we see about a 3-fold increase in marijuana use, but an 8-fold increase in hallucinogenic use, 5-fold increase in inhalant use. And for many of you, especially younger clinicians, this might be really novel. Almost 25 years in the field. I remember when huffing was kind of a big thing and was really surging in the early 2000s. Many of you may never have experienced a challenge with buying keyboard cleaner, right? You're old enough like me that you used to buy one can that would last you 30 years because how dirty does your keyboard get? And I remember the first time I was actually doing mobile crisis work out in Arizona, and I went to this client's house, and his trash can in his room was filled with like 15 empty keyboard cleaner cans. And I just made the assumption, like, are you huffing that? And he got super defensive. And I'm like, yeah, but my question was, are you huffing that? And he admitted he was. And I was like, huh, who would have thought? And it got so bad that now you have to show your driver's license when you buy it. They add this agent that smells very bad because, of course, if something about drug use is unpleasant, people won't use it, right? We all know this. And clearly, I'm being very sarcastic because virtually everything about drug use has a pretty undesirable element. And so to assume that making it more unpleasant with an odor or scent is is fairly revelatory about how lawmakers understand the problem and how us as practitioners understand the problem. We do see that, there's almost a doubling of most other substances, including prescription sedative use and meth use. And I talked before more about meth. I'm going to get into a little bit more about meth today as well, because I really, really believe, and many of you, especially in rural counties, can bear this out, that we have got to say, yep, we've done a pretty good job now of addressing opiates. Now let's look at what other problems are out there and still a big deal and a growing deal. And I got to tell you, friends, if we do not get in front of methamphetamine, we are just awaiting a disaster. And my major fear here is that we're seeing more and more individuals who are causing permanent neurological damage from meth use. And these are individuals who are going to fill the few psychiatric beds that we actually have and are not going to get any benefit from it. Individuals who are going to essentially be in a permanent state of drug induced psychosis that's going to require probably some type of skilled nursing care. And or incarceration and or who knows. But this is a big deal. And unfortunately, we've not had the right victims yet to generate the type of public outrage that we need every time we really start to take a drug problem seriously, right? And I don't mean to make that sound crass, and I certainly do not personally believe that one victim is more deserving than another. Don't misunderstand me. But in terms of why did we start focusing on opioids? Not because we looked at the data and saw it was a growing problem, but because who was affected turned to these, upper middle class, white, suburbanite adolescents that were more readily identifiable by lawmakers. And quite frankly, that's what motivated the change. Meth still is largely rural, although it's now showing up much more in even the most urban settings. It has historically been associated with lower socioeconomic status, all things that unfortunately don't lend themselves well to lawmakers taking action. I want to zoom in a bit to 2023. And I want to focus on now the comparison between past year and past month use, because we have both sets of data here. So the first thing I want to highlight here is that what we see for regular use is borne out largely in what we see in past year use. And that's why, we can still use this earlier data from the survey to inform us. But when we look at like past month use, and what's great is that they throw in things like tobacco products, including nicotine vaping, which they now separate out from traditional tobacco products, and they throw in alcohol use. So just as a reminder, alcohol use still very common, ubiquitous. We all know this. We also know that It has been a challenge for a long time to really find or operate true dual diagnosis facilities. And the IDD requirements are that have been coming out. Yeah, those are a good idea. None of us would disagree. Now we just would love the funding for both the clinicians and for the facilities. Um, like this is not something that anybody is neglecting intentionally. This is something that comes down to resources and how important is it to us. Now, when we look at again the 30-day versus year, it tells us something about regular use. And what it's telling us is that, the people who are regularly using that 43.6 million, people 12 and older that are regularly using marijuana, that's more of our real target of concern, right? Now, obviously, one theory of, substance use is that it's for self-medication. And I believe that while we all acknowledge this, I don't think we are always interpreting some of it in the way that we maybe would benefit most from. So if we look at not just, you know, individual drugs, but how the drugs are clustering, I think it's telling us more about what people might be self-medicating. So it shouldn't be very surprising that as more and more people are reporting anxiety-based disorders, that we're going to see drugs that have some type of anxiolytic, that is anxiety reducing, mechanism, or soothing, calming, altering, are going to really usurp what we have seen with the preference for stimulant based drugs, cocaine, meth, prescription stimulants, right? Those are not going to make people feel better if their primary reported concern is an anxiety based emotion. So I think we need to notice that. And I think it's also important to note that, like, in terms of opiate preference, we're still seeing a pretty big differentiation between prescription opiates and the traditional opiate of heroin. And again, this I think is important when we try to tell the story of the dangers of things like fentanyl and all the, derivatives such as carfentanil, et cetera. The truth is that people prefer them because the high is different and it's more sustained and lasts longer and this is vital because if, as treatment providers, we need to be asking that question of what is this doing for you and how are we going to replace what it's doing with something that's less harmful, right? And the core principle of substance use treatment is that if we're going to remove somebody's drug of choice, we're going to get them sober from something, we have to be replacing it with things that work as well. And boy, not much really chills you out, like oxycodone, right? Fentanyl. Like, it's hard to replace that with bubble baths and journaling, right? And we can be candid now because we all work in this field. I think very often we greatly minimize what people are losing when they try to get sober. And it might also explain why it's so difficult to maintain sobriety for some of these drugs. Um, I I saw a billboard one time that read, "Get high on life, not on meth." And while I appreciate the sentiment, I also couldn't help but feel a little bit like, there's a difference between a meth-induced high and a hike in the woods. All right. And I feel like one of the things that really benefits us, and this, by the way, is why, peers are often so compelling when they're used in treatment roles, is that statements like this often reflect somebody's unfamiliarity with the substance, which thank goodness. We don't need more people with firsthand knowledge. We just need to, find those with firsthand knowledge, who have been, successful in managing their illness and recruit more of them to work with us. But probably should not just use them in direct treatment, probably should use them for a lot of our marketing, promotional, public discourse around it, because I think we miss a few things. And that's an opportunity for all of us to grow. And what I want to say about that as well is that if we can hear firsthand what the experience was, it only better informs us like what to be asking our clients and what we need to be thinking about in terms of the collection of interventions and support mechanisms we're going to help put in place to help somebody achieve their stated goal of sobriety from something. So if you do have access to peers, buy them lunch and have them tell you about some of these things. Um, really let them be the experts. It will only improve the quality of the service that you deliver to the rest of your clients. Now, getting a little deeper into some of the inferences we were going to make, um, this demand for drugs that mellow, such as THC and opioids, over those that excite, really is, I think, confirming that anxiety-based responses, uncertainties in life, desire to escape, all really are the primary problems that people are presenting with. I see that in my private practice, my wife's private practice. I've seen that in ER admissions. I think this is fairly self-evident. However, I don't always think that we think about how these two things correlate. And we also don't think about how self-sabotaging we are in terms of uh, the degree to which we're responsible for our own heightened senses of anxiety. We've only recently, in the past couple of years, been talking about how, things like doom scrolling are really contributing to this, how too much consumption of news and information, especially given that news organizations now have sadly really become more about the profit. And so they're using headlines, the clickbait that really disproportionately like create a sense of fear, of uncertainty, of danger. And we know that even just seeing that headline without clicking on the story, without reading it, just trying to get past it, signals to our brain that there is more danger. And that is going to lead us all to be slightly more hypervigilant. And the more we indulge in that, the more our hypervigilance grows. And now we're off to the races. The other big trend, and I think this was in many ways influenced heavily by what happened during COVID, is that the trend appears to be more towards drugs that are readily available domestically, because they can either be directly grown or lab produced domestically without having to rely on traditional import-export services. Now, obviously, there's still a lot of these drugs coming, across our borders. But one of the things we're going to see is that a whole lot more is being produced domestically than was prior to 2020. And a big reason for this is that the lockdowns of 2020 during COVID really forced people to kind of have to change their use, change their preferences. It might help explain why certain drugs became more popular after 2019, that they could be accessed still. And, this is something that, again, lawmakers and far too many policymakers don't understand, that just because somebody loses access to their drug of choice does not mean that they choose sobriety, right? I wish that made it so, but more often what we see is somebody shift their addiction, their preference to something else. And there's a lot of payoff from switching to other drugs. They can be harder to detect. So just considering the varieties of fentanyls, it is not difficult for somebody with a chemistry background to change a formula for fentanyl into something slightly different that would require a test specific for that version to detect. 7-panel, 9-panel urine drug screens. I think most of us who've used those can attest to the fact that they clearly miss a lot. And so that remains an ongoing concern, that an appeal of these drugs is not just that they can be acquired or produced domestically, but that they might be easier to hide or camouflage from people who might be providing oversight. The other and final trend I wanted to talk about today is this strong desire for what appears to be the hallucination type effect that people are getting from drugs, both in the rise of direct hallucinogens and when we look at the psychoactive effects of the top drugs of abuse. This is a theme. And obviously, this puts on us as clinicians a pretty big burden to be able to, differentiate between a drug-induced state and more of an organic state. We know that unfortunately, we have misdiagnosed many people that had a substance use disorder with having a psychotic disorder. And again, when we've got so few resources for treating people with serious mental illness, that matters. We want to make sure we're properly identifying them. We also don't want to be misidentifying, misdiagnosing somebody. I remember a time when I was working in the ERs that a new clinician diagnosed an 8-year-old with schizoaffective disorder. And it was a great teachable opportunity. Unfortunately, she was staffing it with me before she finalized her charting. We were able to come up with a diagnosis that was somewhere in the realm of humanly possible. And, I've noticed a trend for a long time, and I even noticed it especially in my MSW students, that there's often this desire to give people more serious diagnoses, maybe because it's more thrilling or exciting, or you get to brag about your caseload. And usually a year or so in working in community mental health will cure you of that desire, but fewer and fewer MSWs especially are spending any time in CMH, which I think should actually be a requirement. But like many of my ideas, nobody cares what I think. But I'll put it out there. Maybe you have the ear of somebody who's open to change in a different way. But the reason why I think this is important is that I still see a lot of misdiagnosing of psychotic disorders, both missing the early onset stages and, frankly, cases that most likely are not related to an organic illness, but rather to the intoxicating effects of the substance. And as this desire seems to increase for hallucination type effects, which again is altering reality, allowing people to escape, I think it's going to become even more of a challenge in our diagnostic process. I wanted to talk a little bit more, and I know we're starting to run out of time, about THC specifically, just because I mentioned last time that mode of delivery was concerning. Beginning in the 2023 National Survey on Drug Use and Health, they started to ask questions specific to the way that people are taking in their THC. But one thing that occurred to me and has been confirmed in conversations with clinicians around the state, with my grad students, is that there's still some fundamental knowledge that might not be there. So when we talk about THC, we're talking about not just the tetrahydrocannabinols that exist in different structures in different plants, but the delta 9 THC isomer in particular. Now, it's been a long time since many of you had chemistry. You don't need to get too hung up on that. Just know you need to know that it's the unique psychoactive, type of THC found in marijuana. Now, CBD, which is ubiquitous and is, touted that will basically be a panacea. It'll cure everything, even though the research does not bear out its benefits in many areas. It's important to note that CBD itself is not psychoactive unless it is superheated. We do know that CBD partially converts THC when it's heated to temperatures above 480 degrees Fahrenheit. And this is one of the concerns that people have had with vaping devices, is that specifically vaporizers that can heat something up, even if something is a THC CBD blend that they're vaping, that superheating can actually increase the quantity or the percentage of THC in the product. And we get into very high percentages. So when we think about the plant itself, the leaves of the marijuana plant only have 1 to 2% THC concentration. It's the flower, aka the bud, that has the majority of it, and that's at 15 to 20%. So if somebody is smoking it in a bong or in a joint, they're getting that 15 to 20% THC concentration. Now, fun fact, 50 years ago, the THC content of flower buds equaled that 1 to 2% we now see in the leaves. So as cultivation has improved, and I have to tell you, some of the most strategic minds in the scientific community have devoted their efforts to marijuana promulgation and have become quite artistic and have really changed. So for those of you who will hear your parents, grandparents, some of you are so young, maybe your great grandparents talk about, the weed they used to smoke. When people say it's different now than it was, this is what they mean. They mean that it is far, far, far higher in the THC concentration. And the higher the THC concentration, the greater the magnitude of effect and the greater the risk for developing a psychotic response from the intake. This is why things like the waxes, why the edibles can have such an intense effect. Now, an article that just came out this year took a look at detectable THC levels in blood plasma by the mode of administration, and that's what we see in this graph. So the dabbing, that is taking in the higher concentration from the resins produced with THC, these waxes, resins, this by far increases, the amount of THC in our blood much, much higher. Actually followed by taking in the bong-like mode, which allows for a much higher amount of smoke to enter the lungs, then vaping and joints at the very end. Now, interestingly, though, when we look at subjective intoxication, that is, how are people experiencing this over time? 1 hour after use, while that acute phase, people who were using dabs, waxes, etc., had the highest level of intoxication and the highest reported intoxication, they actually reported the lowest sensation an hour later. And part of why we need to pay attention to that is it means that their desire to use again is higher. And this is a phenomenon similar to what we see with crack cocaine versus powder cocaine, where the high from powder cocaine might last, much longer than the brief high that comes from crack, which increases the need to use crack more frequently. And so what we can say is that the ingredients for a psychological dependency from using things like dabs does appear to be a bit higher than it does from even vaping, because vaping tends to last a little bit longer. And traditional joints, they don't have the highest report during use, but the second highest, and it has the highest effect 1 hour post. So for those of you who do take a harm reduction mode, clients found and determined to use marijuana, smoking a joint is preferable to other methods for myriad reasons. Link to that article below. Make sure you check that out. Really fascinating, really eye-opening. Do want to talk briefly also about meth and what we're seeing in terms of the meth that's out there now. So we know it's changed significantly. And one of the biggest reasons for that change was the federal legislation that made it so difficult to access the core ingredient, which was ephedrine or pseudoephedrine. But more concerningly, we've seen traditional meth being made in new formats. Also, we've referred to this as either one pot or shake and bake. This is, again, making the traditional form of meth, the meth that gets people high for days on end, chatty, social, take apart everything in their house, other people's houses. Um, we're now also hearing more people refer to this as dirty meth because of the predominant meth that's available, the P2P that I'm going to talk about in just a moment. The new production, the one pot shake and bake methods, produces a comparable high with a much, much smaller and mobile setup. And when I say mobile, I mean you can make it in the back of your car. You can make it with 1 or 2 2-liter bottles. I'm going to show you some pictures of the differences in labs in just a moment. Fewer steps involved, but it is a much more volatile process. And that's saying something because meth production is already incredibly volatile. There is a great flyer on what to look for to spot signs of one pot or shake and bake meth production. I link to that here, and you'll have access after the webinar to this PowerPoint. So make sure you check that out if you do any kind of like home-based work, going into homes at all, or any of your staff do, make sure you check that out. But the meth that constitutes 90%, 96% of all the meth in circulation today is now referred to as P2P because of its chemical makeup, which is actually a formulation that takes us back to the prescription style of meth that was once prescribed in the US. Technically still is, very, very limitedly. For those of you more chemically inclined, it's the D isomer. And it is made without any ephedrine or pseudoephedrine, instead basically taking acetone and chemically synthesizing it. What is most important, I think, for us to recognize is that now this is the most ubiquitous type of meth, and it produces a very different high, a shorter, more intense high that's actually associated with isolation instead of that gregarious engagement. It's also got a much higher incidence of psychosis. So the reason why we've been seeing more and more, meth-related psychosis, it already was a great causative agent, and we discussed that back in February for psychosis, but now it's almost ideally synthesized. The traditional old method of producing methamphetamine required quite a big setup, multiple stages, a fairly sophisticated understanding of chemistry and extraction methods. The new process requires your unreturned recyclables and basically not much else. So really concerning because it just means the accessibility is so much higher, and higher accessibility will lend itself to greater use. Touch on xylazine real quick. I did mention this before, but we're seeing a lot more of this. It's again an animal tranquilizer, primarily being used as a cutting agent, although there are people who are specifically seeking it out alone as a standalone. It extends and magnifies that mellowing, sedating effect of opiates, but it's also highly caustic, associated with skin ulcers, and again, increases that risk for overdose without responding well to the traditional, Narcan overdose remedy. And unfortunately, I need to end on a sad note. The Drug Abuse Warning Network, which I referred you to last time, is, as part of our current administration's cuts, discontinuing new data collection. So we will no longer have this resource to keep us abreast of upcoming drug threats, despite the number of people who are dying of drug overdoses, being incarcerated, etc. So that's wonderful. All right, and that's our show for today. I'll go ahead and now hand it over to Olivia, who can help facilitate some of our Q&A.
Thank you, Scott. That was amazing information. Yeah, you're right. A little bit of a bummer there at the end, but that's the world we're living in, so might as well not pretend like it's anything else. But yeah, thank you so much. And yeah, as you can see, and as I'm sure everybody agrees, this really is robust information that could have up to 40 parts to it. So you've got, a standing invitation, I guess, to the COP, which I don't think anybody would object to. But yeah, I want to open it up for questions. I know we're approaching the end here, so if there's any burning questions we have for the end,
And
any?
I did want to acknowledge real quickly Paula's comment about Kratom in the in the chat. Would love to talk at length about Kratom. I really expected the DEA to ban it a long time ago. Interestingly, the countries it grows naturally in, like Thailand, have long outlawed it. But this remains something that you can buy, and I think it is responsible for a lot of the um, presentations to ERs we see that mimic either an opiate-based response or a stimulant, because depending on the amount you ingest, you can get either effect. So kratom, yes, we need to talk about that at length.
Yeah. Seth, I see you came off mute.
I did. Thank you, Scott. Always a pleasure to listen to your presentations. I thoroughly enjoy it. I appreciate your balanced approach as well as having a similar philosophy about recovery in general. And I just want to talk about some trends because I'm in a rural area and we're
Right.
seeing exactly what you discussed. And it tends to happen in pockets, areas of Tuscola County, which is fairly sizable, but not a great population size. And we see these things rooted in areas where people will come out of the woodwork, zero history of mental health issues, zero history, nothing, no, this is my first time. And they are actively psychotic. We're seeing more substance-induced psychosis, and these people are not getting better.
Yeah.
They're not. Their lives are forever changed from this. It's different than your typical alcoholism or even a cocaine addiction, which people can recover from. Heroin, same thing. The stuff that's cutting these drugs that are out there is very dangerous, and I think your pictures spoke very loudly to that. And for us, it's understanding there's no way to really get in front of this. But the responsiveness in trying to help people abstain once they get connected to us, that's our next challenge. That's our next wicked problem.
Yeah.
Uh, because, like I said, the Coke bottles, people are making this stuff in the backyard. They're, adding whatever they want to it, and um, I think we would all be well served to kind of use that as an educational tool for the folks we work with.
Yeah. Yeah, and I think the scary thing too is that, and I know I briefly touched on this back in February, but, really most antipsychotics don't seem to be effective with this type of psychosis, right?
No, they are not. They are not.
And yeah,
No.
and so really it creates this environment where how are we going to handle this if they're not going to be coming out of the psychosis, if it is potentially permanent, because frankly, we know it's destroying the same D2 receptors that, relate it there. And so at some point it's, we're left with a neurological injury, not a substance use disorder. And how are we going to classify that? How are we going to diagnose that? Who's going to pay to treat that? Like, we're
Yeah.
not geared up.
Yeah, we're not, and that's the thing. And the medical people point at the mental health people, the mental health people point at the medical people, and we're kind of amidst that right now. I know Shannon's
Yeah.
on, she's in here as well, and we had one case we've been working on for about 2 years, where this is a longtime recipient of our services, lower level mental health needs, and occasional psychotic break, and I'm not minimizing, but compared to what we're seeing now, those things are rather minimal.
Yeah.
And she got tangled up with you use the phrase dirty meth. That's not the first time I've heard that. And and that's out here too. And she is a shell of her former self.
Mm.
And it's
That's
been 2 years and she is not getting better.
yeah. Yeah.
So I don't know. I imagine others are seeing that same thing as well. But these substances are really rocking the mental health system.
And I think this is unfortunately a contributor to the fact that we're not doing more about this, is that, we so often rely on, information from suburban and urban counties. They kind of have the larger voices, and we
Yeah.
miss the majority of the state is rural, and that, you know, we need to be hearing like, what are the rural problems, because they won't stay rural problems, as
Exactly.
all of history has taught us.
Yeah.
And
Yeah.
indeed, you know, like Oakland County, we've seen so many large meth busts now, large meth labs and strip malls, think like this, we know this is a problem, and yet people are still acting like, you know, opiates are this new threat that we've got to do something about. And it's like,
Yeah. Yeah.
it's hard.
Yeah, and we have, and Tuscola County is unique because we have the pipelines and we have the lakeshore. So
Yep,
we've got, we've got M81 coming out of Saginaw, we've got M15 coming out of Flint. And if you just slide over into Sanilac County, you got 53 coming up out of East Detroit, Sterling Heights, that area. And so we're not a stranger. All these things float into our area and it stops at the lake. It doesn't, it stays there. And the people stay here too. So that's,
yep,
we really have an epidemic compared to some of the other counties because of our size and because of our lack of resources, yet our problem is magnified
exactly,
by those factors.
exactly. Constance, you brought up a great point about the rise of hallucinogens. Yeah, the popularity of microdosing, the prospective promise of, you know, therapeutic uses for psilocybin. I think that does contribute. I also think that a small increase in interest for microdosing and therapeutics has also made this very old drug new again. And so I think there are multiple pathways that have increased the use of hallucinogens like psilocybin, that some people are like, oh yeah, that's a drug I haven't really heard much about because they're, you know, 14, and they didn't have the lived experience that some of us who are not 14 anymore have had. So I do think there are multiple pathways. And, you know, one conversation we need to start having is some of these substances that are drugs of abuse clearly are showing a potential therapeutic benefit. And it's just like prescription opiates. Again, I had surgery yesterday. Pretty grateful that I did get some fentanyl as part of my surgical pain management. Because yesterday, like, I gotta tell you, like, I didn't have that much pain. And today I'm like, something's different. So clearly, like, we recognize that it's not the substance itself, it's how it's utilized. But this does raise a lot of questions, because if we start using, you know, more of the ecstasy, the psilocybin, et cetera, for therapeutic benefits, it will be putting a stamp of, quote, safety and approval on these drugs used as a medication now, that will likely increase their use and abuse. So this is something I think we need to be having conversation around before we see some accelerated decisions.
Yeah. Well, thank you so much. Thank you everybody for staying on this conversation. And around SUD and SMI is always so robust, and I appreciate it very much. And yeah, just to end it, I want to bring attention to Jenny's comment in the chat about kind of bringing it back to AOT and just reinforcing that AOT is not an appropriate intervention when it's only SUD is the presenting problem, and this can often be something presented in hospitals where that may the clinical history is not always there, and that can be something that can come up at hospitals as well. So but we wanted to share this information to help make appropriate assessments. So thank you all so much, and I hope you have a great rest of your weekend or great start to your weekend, and we'll see you next month.